Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Stoke Therapeutics, Inc.
Hello, my name is Dr. Joseph Sullivan. I'm a pediatric epileptologist and professor of neurology and pediatrics at the University of California, San Francisco. I'd like to welcome you to this program titled The Genotype-Phenotype Connection in Dravet Syndrome, Preparing for the Future. In this lecture, I will review the symptoms associated with Dravet syndrome. We'll also review how variants, pathogenic variants in particular, in the SCN1A gene are thought to lead to all of the core symptoms that are associated with Dravet syndrome. And that actually will highlight some of the potential disease-modifying therapies that are actually under development. We'll also go over some of the current medications that are being used and why there still is this unmet need for some of these disease-modifying therapies. So Dravet syndrome is, of course, a syndrome, so it's much more than just seizures. It involves developmental slowing and stagnation, often leading to intellectual disability in the moderate to severe range. There's also very prevalent attention problems. Many patients have autistic spectrum features, and later on also develop motor and gait problems. Furthermore, there are many other behavioral and sleep disturbances that are very prevalent in these patients, and this really does contribute to the overall quality of life that these patients and their caregivers experience. And lastly, we sadly know that there's an increased mortality in many patients living with Dravet syndrome, largely due to an increased risk of sudden unexpected death in epilepsy patients, or SUDEP. Patients with Dravet syndrome typically are developmentally normal and will present with their first seizure around 6 months of age. That seizure is often prolonged and often in the setting of fever, although it does not always have to be. So you can still have a presenting seizure be a 2 to 3 minute seizure without fever, but then it's the subsequent evolution of those seizure types over time in an otherwise developmentally normal infant with no other underlying etiology for their epilepsy, where someone really should start to think about that patient having a pathogenic SCN1A variant and therefore a clinical diagnosis of Dravet syndrome. Despite the changing seizures over time, we also see this slowing of development after seizure onset. So the kids still make developmental gains, but at a much slower rate than we would expect compared to their neurodevelopmental peers. And so when you extrapolate that over time, there is this widening gap. And so they continue to make slow incremental gains, but if it's being done at a much slower rate than their neurotypical peers, when you extrapolate that over 5, 10, 15 years, that gap gets significantly widened. And that's why many of these patients fall into the moderate to severe intellectual disability range. As I've mentioned, the majority of patients with Dravet syndrome do have a pathogenic variant in the SCN1A gene, which is found on chromosome 2. The SCN1A gene encodes for the alpha subunit of the NaV1.1 sodium channel, which is primarily expressed in the GABAergic inhibitory interneurons. And understanding the underlying pathophysiology of this sodium channel and where it's expressed is actually really important as we start to talk about other novel therapies that are in development. So what happens when you have these pathogenic variants in the SCN1A gene? So what happens is if you have a variant in one of the genes, that leads to a loss of function. So essentially no sodium channel is made from that one transcript. And this results in this, what we call haploinsufficiency. So essentially in a normal person, a normal patient, we have 2 working copies of the SCN1A gene. But in Dravet syndrome, one of those copies has a pathogenic variant that leads to this loss of function, and therefore that one gene cannot make the sodium channel. And so you end up with this haploinsufficiency and leads to 50% less of that sodium channel being expressed. There are many different ways that these variants can lead to this loss of function. You can have missense variants, you can have truncating variants, and you can even have these aberrant splice events or this poison exon that actually leads to this nonsense mediated decay. And essentially, that protein is not able to be translated into the functional sodium channel. And so when that happens, and these inhibitory interneurons do not have the full complement of sodium channels, that reduces the excitability of these inhibitory interneurons, right? So you have an interneuron that's main function is meant to be inhibition. And so because of this haploinsufficiency, that neuron is unable to inhibit as it's supposed to. And so when you end up with more excitation because of the reduced inhibition, right? So it's this seesaw, it's this teeter-totter. And basically that leads to this more widespread reduction in the inhibition of the overall network. And that's why it leads to seizures. And we also believe the other non-seizure neurodevelopmental findings. So evidence so far suggests that the impaired GABAergic signaling in these Purkinje cells can also lead to some of the motor function. There's also some basic science hypotheses that suggest that the increased risk of SUDEP in these patients may be due to the increased parasympathetic activity following tonic-clonic seizures. And then again, Dravet syndrome being much more than just seizures. All of the behavioral and cognitive impairments we feel are in some ways modulated and mediated by this reduced GABAergic interneuron expression. So therefore, Dravet syndrome, we look at this as not only a developmental and epileptic encephalopathy, but more specifically a channelopathy due to this aberrant expression in that NaV1.1 protein. So how do we currently manage patients with Dravet syndrome in 2025? So there was a group of key opinion leaders that got together back in 2017 and then again in 2022 to sit down and really come up with a consensus statement or guidelines to help guide us and our colleagues in terms of the journey that these patients could go through as we have more options available to us to manage their seizures. The reason why this was done twice in that short 5-year period is because thankfully new medications became available and we had nice phase 3 controlled trials with safety and efficacy data to help guide us and support the use. These consensus statements really settled on valproic acid as being the first line treatment, even though there actually is not great data supporting the use of valproic acid. It's been around for decades and really as a prototypical broad spectrum anti-seizure medication. We have learned through many of our colleagues in using this over time that it can be a very effective treatment in the management of seizures in Dravet syndrome patients. Unfortunately, this does not get many patients significantly reduced in their seizures for a long period of time. And so that's why we do this sequential add-on polytherapy where we're adding on a new medication and then assessing which medication ideally can be taken away. The goal here is to try and get seizures as decreased as possible, but not at the expense of intolerable side effects. And we do know that as you add on additional anti-seizure medications, the risk of those side effects does go up. So I find, a medication regimen of around 3 medications is really optimal. And so how do we add on those medications? This consensus guidelines showed that after valproic acid, fenfluramine, stiripentol, or clobazam are really the medications that should be discussed as that second line. After that, the consensus was pharmaceutical grade cannabidiol. And then after that, really the gates are wide open with topiramate, ketogenic diet, vagal nerve stimulation, levetiracetam, and others. This is not meant to be prescriptive in any way. When I sit down and talk to my patients, I present to them the data and present to them my clinical experience with each of these agents. So if someone wants to start one medication over another, as long as I feel that's reasonable and within this framework, we'll have that discussion. And I try to tell families to not get stressed out about which one is the best, because every patient's going to respond a little bit differently to each of these medications. And unfortunately, in the big picture, the overwhelming majority of patients with Dravet syndrome will ultimately try almost all of these medications so that we actually optimize that sort of regimen for that individual patient. Equally important in this consensus statement is the avoidance of sodium channel blockers. And the main ones are carbamazepine, oxcarbazepine, lamotrigine, phenytoin, and lacosamide. And the reason why is because of that underlying pathophysiology of the haploinsufficiency and loss of that sodium channel expression in inhibitory interneurons. These medications can actually exacerbate seizures, and there's actually been some studies that have actually shown can have a negative impact on the long-term developmental outcomes if they've been on these sodium channel blockers for more than 11 months. One note is that phenytoin, while it is a sodium channel blocker, it is a commonly used medication for the acute treatment of status epilepticus. And there are Dravet patients where this is an effective medication to be used as an IV load in the setting of status epilepticus. And so that's not contraindicated for that purpose, but it's contraindicated for the daily sort of maintenance use. So when we get into all of the other non-seizure related comorbidities, there's really not consensus about the best way to treat them, specifically in a Dravet syndrome patient. So we often use our experience of treating, say, ADHD in other patients, and we use stimulants. That's not to say that there might not be more nuanced or better approaches to the treatment of attention problems in patients with Dravet syndrome. It's just we don't really have great data to guide that. In terms of addressing some of the motor and gait problems, physical therapy, occupational therapy are critically important for these patients. There's even some observations that in older adolescents and adult patients with Dravet syndrome that they develop some Parkinsonism. And there's actually been some trials of levodopa that can actually be beneficial in some patients. Sleep disturbances are so common. I almost don't even ask how my patients are sleeping or ask parents how their children are sleeping because I almost know the answer is always not well. And we really do need better treatments for these sleep disturbances. We still try things like melatonin and clonidine, and those can help, but sleep is a big problem in these patients. And when the child's not sleeping well, the parent's not sleeping well, and again, that contributes to the overall quality of life for these patients and their families. And then a really controversial or I guess emotionally charged topic is vaccinations. Many of these patients do present with their first seizure shortly after a vaccination. And initially, families may actually think that that vaccination was the cause. We now know by looking at some studies and outcomes that while vaccinations actually can be a provoking cause of that first or second seizure, it by no means is the cause of Dravet syndrome, right? We know that that's caused by these pathogenic variants in the SCN1A gene. So we really strongly urge all of our patients to receive their routine vaccinations. And if vaccinations are triggering, then sometimes we use antipyretics to reduce the fever that's associated with vaccines, or sometimes we'll even start like a short 2 to 3 day bridge of low dose benzodiazepines just to get those patients through that high risk area, that high risk time to prevent a seizure from happening. So we obviously have a lot of treatment options available for our patients with Dravet syndrome, but as I've highlighted, there's still a huge unmet need. As much as we're doing better at reducing seizures, seizure freedom is rarely an achievable goal. And I tell that to my families when I'm talking to them. Certainly, we want to try to get them to being free of the prolonged status epilepticus seizures. And we also want to try to get them as long as seizure intervals as possible, right? So if we can get a patient to have a seizure every 2 to 3 months, which I do think is achievable, I look at that as a realistic goal. But that's not to say that we shouldn't be continuing to work and develop novel therapies that ideally can get more patients to seizure freedom. And I think the other thing is that just treating the seizures, as I just talked about sleep and behavior and attention, just treating the seizures does not addressing all the aspects of the syndrome that have that negative impact on quality of life. And so the hope now moving forward is that understanding the underlying pathophysiology of Dravet syndrome and the linkage to that SCN1A NaV1.1 haploinsufficiency is, are there going to be disease modifying therapies that can not just treat symptomatically and be anti-seizure meds, but rather get at that underlying root cause? So what are the therapies that are on the horizon? There's a couple that we're going to focus on that are further along in clinical development. And again, both are approaching it in slightly different ways, but are trying to restore that underlying haploinsufficiency as a result of the pathogenic SCN1A variants. And the reason why I think these are really important is because if we're getting at the underlying cause, we have, I think, a better chance of actually addressing all aspects of the syndrome. The first one that I'd like to talk about is called ETX-101. This is an AAV9 associated vector-based therapy. And the AAV9 capsid is housing a genetically engineered transgene that is specifically targeting the GABAergic interneurons. So not only are we trying to increase that expression of the NaV1.1 channel, but we would love to do it with some cell specificity, so in those GABAergic interneurons. And so this transgene encodes for a transcription factor that binds upstream of the SCN1A and promotes increased transcription of the messenger RNA, which then goes through and results, thankfully, in increased functional NaV1.1 production. Another therapy that's in development is called zorevunersen, and this is an antisense oligonucleotide that's targeted at the specific exon that has led to this nonsense-mediated decay. And so it's sometimes called a poison exon. Sometimes we don't like using that term because it sounds too scary, but essentially it makes non-productive messenger RNA, which again does not get translated into NaV1.1 protein. By promoting exclusion of that exon, you actually turn that non-productive messenger RNA into productive messenger RNA, and therefore that is able to lead to increased production of the NaV1.1 protein. And so what data do we have that show that these two therapies are even ready to enter into the clinics? So in 2 mouse models, ETX-101 did demonstrate increase in the SCN1A transcripts, specifically within the GABAergic inhibitory interneurons. In these mice, we know the mice left untreated have early death. And so one of the outcome measures in the mouse models is to show that there's prolonged survival, and the studies of ETX-101 did in fact show that. And furthermore, a very common model that we use in the mouse is to heat them up. We know that human patients with Dravet syndrome are sensitive to fever and hypothermia-induced seizures, and so we can do the same thing in the animal model by warming up the mice. And so in the mice that were treated with ETX-101, there were reduced spontaneous seizures as well as reduced hypothermia-induced seizures. Then moving on from the mouse model, ETX-101 has been studied in non-human primates, and this has to be given through a unilateral intracerebral ventricular injection. So there's a small burr hole drilled into the skull, and then a catheter is placed where it's delivered into the ventricle. And then when those non-human primates were looked at later, it was clear that this transgene was expressed throughout all areas of the brain, including the regions that we feel are most important for the treatment of seizures and the neurocognitive deficits. And so in the non-human primate studies, the injections of ETX-101 were well tolerated. There were really no adverse events during administration. There were no changes in clinical observations, body weight, or temperature during the study period. And there were minimal to mild elevations in the transaminases, so the ALT and the AST, which resolved without treatment. I want to highlight that this non-human primate model is not a Dravet model, right? These are normal non-human primates. So they have normal SCN1A expression. And so by giving ETX-101, we're actually upregulating the sodium channel production above what is actually normal. In contrast to what was happening in the mouse model. The mouse model was a mouse model of Dravet syndrome where they do have the haploinsufficiency and have spontaneous seizures. So the non-human primate studies, because there's not a non-human primate model for Dravet syndrome, are really just trying to get at the overall safety in a species that most closely approximates humans. So a phase 1/2A study is currently underway in the US, the UK, and Australia. They're currently recruiting patients between the age of 6 months and 7 years. There are different dosing levels that are being looked at. And again, this is being delivered by a single one-time intracerebral ventricular route. And then because this is an adeno-associated virus, There is an immunosuppressive regimen that's actually required to prevent the immune response, not only to the AAV9, it has to have a chance to actually transduce and transfect and deliver this transgene. But at the same time, we also don't want the immune system to have a response to that transgene. So this immunosuppressive regimens are important in the short term after giving the AAV9 therapy. The second therapy I'd like to talk about is the zorevunersen. So this works by a different mechanism that is abbreviated as TANGO, which stands for Targeted Augmentation of Nuclear Gene Output. This has also been studied in the Dravet mouse model. And so essentially what this TANGO does, as I mentioned before, is it excludes this exon that results in a non-productive splicing event. So the way I sometimes explain it to patients is you have the do not disturb sign on the hotel room, and this ASO goes in and takes that do not disturb sign off and allows that messenger RNA actually to be utilized. And so when this was looked at in the mouse model, it did thankfully what we had hoped it was going to do by increasing the amount of SCN1A expression in the mouse brain. In the mouse model, this was given via a single intracerebroventricular dose, and it again reduced the incidence of electrographic seizures as well as SUDEP in this mouse model of Dravet syndrome. And then in a second mouse animal study, zorevunersen reduced seizures, it prolonged survival, and actually showed that there was excitability in these inhibitory interneurons, almost to the level seen in their wild type primates. So basically restoring that amount of function to those that actually have full complement of NAV 1.1 expression. So that has led to a program with a phase 1/2A open label study that is completed. There were multiple doses that were looked at in the study, starting out at a 10 milligram dose, and then gradually increasing over time to ensure safety. And that dose was gradually increased so that we were up to a 70 milligram dose. Overall, 81 patients between the ages of 2 and 18 have been treated. And these are patients that are still having frequent seizures despite standard of care that I reviewed with you. So they're already tried these 3 or 4 anti-seizure medications and unfortunately are still having often 10 or more convulsive seizures per month. So highlighting that even though we're doing better with those new medications, there are so many patients that still have an unmet need, and these are the patients that are enrolling into these clinical trials. And so I'm happy to report that at the multiple doses of 70 milligrams, as we got up there, we realized that the lower doses were safe. And so we landed at 70 milligrams as a loading dose. That 80% of patients have experienced a 50% reduction or more in their convulsive seizure frequency at 3 months, and that actually at 6 months, that reduction is very, very similar. And what we're really excited about is not only are we seeing this profound reduction in seizures, but we're also seeing improvements in adaptive behavior and overall clinical status, which is really translating into improved quality of life within these first 9 months of treatment. Overall, the doses have been well tolerated. The most common adverse events have been increases in the spinal fluid protein, as well as some vomiting that is more likely attributed to the lumbar puncture procedure rather than being an adverse event of the medication itself. And then after these patients were dosed in the initial phase 1/2A, they were allowed to continue in an open label study and continue to get dosed at a lower dose than the 70 milligrams. And so by giving those patients 70 milligrams up front for one cohort and then continuing to dose them at 45 milligrams at longer intervals in between every 16 weeks, we actually saw durable reduction in the convulsive seizure frequency and ongoing clinically meaningful improvements in this cognition and behavior. So this has been inspirational in a way to see that not only can we reduce seizures and improve some of these non-seizure outcomes with these doses up front, but that we can then use lower doses that's spaced out over longer intervals and that the treatment effect is actually durable. The most common adverse events that we saw in the open label studies were also the increase in CSF proteins, but thankfully this is not translated into any concerning clinical signs. It's something that we're continuing to follow in the studies, but so far the numbers, again, have not translated into any clinical concerns. So all of those data from the phase 1/2a study really informed the design of the phase 3, which is a randomized sham-controlled trial. So the gold standard for understanding what effect an intervention has is to have a placebo or sham arm. There's not a placebo that's actually being given to these patients because this medication does need to be given through a lumbar puncture, so it's given intrathecally. And the thought was that the risk of giving a placebo through the intrathecal route did not justify the potential risks. And so what the trial is doing is it's having a sham control where all the patients actually still have the lumbar puncture, but in a completely blinded and randomized way, half of the patients will actually get the active treatment and the other patients will just get the lumbar puncture and the spinal fluid will be collected. And so that's a way to preserve the blind as I'm seeing them as the blinded investigator. All the patients have a lumbar puncture and I don't know which of them actually received the medication and which one did not. And so the primary outcome measures for this trial are going to be countable motor seizures. This has some limitations because we know that many patients with Dravet do have other seizures that are maybe not countable and still are important to their overall quality of life. But if we can't count them reliably, it's going to be really impossible to include them as a primary outcome measure. Another limitation is we need a certain baseline number of seizures for these patients in order to have the expectation that when they're reduced, hopefully with the treatment, that there will be separation from the sham arm. And so the requirement for number of seizures may limit the eligibility. It's not more broadly applicable to the entire community living with Dravet syndrome. But the hope is that if we actually demonstrate efficacy in this group and get approval, then it would actually be able to be prescribed more widely without any sort of baseline number of seizures required. And then some of the key secondary endpoints that we're really, really interested in are those cognitive and behavioral endpoints. And those are actually going to be assessed primarily through the Vineland Adaptive Behavioral Scale, the Vineland 3. And this is something that is a structured interview questionnaire that's administered to caregivers. And again, because we have two groups and we're blinded, we're hopefully going to see that the treated group separates from the sham group in a way that supports this therapy being disease modifying. So some of the caveats about disease modifying therapy that I think are still unanswered questions is timing important? We like to think that in a condition like Dravet syndrome that starts early on in childhood and impacts the developing nervous system, that maybe earlier is better. But I like to say that we like to think that it's never too late. And so we are going to be looking at maybe the timing of therapy. Is there an optimal time? We certainly want to follow for the potential overexpression of SCN1A, even though that was not seen at very high doses in the mouse model. And then when it was looked at in, again, non-human primates, it's something that we want to keep our eye on. And then 81 patients have been enrolled, not 8,000 patients. So we certainly want to be following both of these treatments over time to see if there are any other long-term side effects. But right now, I think the unmet need for patients living with Dravet syndrome, there's a high risk tolerance for this patient population. And so I think as long as these trials are being done with safety in mind and being seen by experienced clinical investigators, I'm really optimistic about how these studies have been designed. So hopefully after watching this session, you can see that this is a very exciting time for our patients with Dravet syndrome. Not only do we actually have better treatments that are available to us today, but there are a lot of novel approaches that are at various stages of clinical development that really are aimed at getting at the underlying cause so that we can not only reduce seizures more, but start to address many of those non-seizure cognitive and behavioral endpoints. And I don't think we're done here. These are two approaches, and there are other approaches that we don't have time to talk about today or that are too early in their developmental stage. but I really think we're entering into a new era for these patients where disease modification is actually possible. So thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.